So this is kind of one of the favorite parts. This is the Ask the Expert panel. So we're going to start by having everybody introduce themselves and tell you what they do at our center. And then we're going to take as many questions as we can. Oh, you already did that? Okay. Can you introduce? So I'm Irene Malati. I'm a neurologist and direct the Center of Excellence here at UF.
I'm Matt Rems. I'm one of the Movement Disorder Fellows and also a neurologist at the University of Florida.
I'm Rachel Dorsey, an occupational therapist at the Fixel Institute.
Hello there, I'm Matt Farah. I'm a neurogeneticist and neuroscientist at Fixel.
I'm Dr. McFarland. I'm one of the neurologists at the Fixel Institute.
I'm Kelly Foote. I'm a neurosurgeon at the Fixel Institute.
Hi, I'm Alana McKay. I'm a licensed clinical social worker at the Fixel.
So what we'll do is one of us will read the question and we'll give you an answer, and then the rest of the panel can jump in if they have more to add. So I'm going to start with, why does Parkinson's make it so hard to gain weight or maintain weight? And it turns out that weight loss is absolutely seen in Parkinson's disease. And it's involuntary weight loss, not planned weight loss. And this has really perplexed researchers for a long time because there are many different factors that might contribute. And it's been hard to pin down, is it only one of those? So some of the factors, one may be that it could be harder to eat if you had Parkinson's affecting you, if you had tremor, if you had slowness of movement or swallow trouble. So people have thought maybe people eat less calories. Another thought is, maybe people are burning more calories because they're moving, or they may have dyskinesia, and maybe that's higher metabolically active. And then people have thought maybe it's something deep down in the hypothalamus or somewhere inside our brain that's affecting metabolism circuitry, and maybe it's medications. Maybe medicines affect our metabolism or our appetite. Finally, Parkinson's causes a loss of the sense of smell, which affects taste directly. And if food doesn't taste as good, maybe that makes us not eat as much. We talked about constipation in this room and how that can cause early fullness. And so it's probably a combination of all of these factors. We have, at the Fixel, we have a dietitian on our team. And if you're finding it hard to maintain the weight that you feel the best at, they can give you advice on nutritionally dense food. I think it's important to touch on another thing that can affect weight in Parkinson's, which is that some people recognize that what they eat affects how well their medicine works. So some people become fearful of eating because they say, well, I have to pick. I either eat or I can move. And if I eat, it makes my medicine not work. Now, not everyone experiences this, and it's usually something in people who have had Parkinson's a longer time. But what can happen is the protein in what we eat competes to be absorbed. So it gets soaked in the same part of our system as the medicine. And so if you have a whole bunch of stuff in your belly, perhaps you don't absorb as much of that dose of medicine. And so people may avoid eating, which we don't want to avoid eating. Instead, we can learn to time the way we eat relative to the way we take our medicine, so that we can give our medicine a head start before the meal, or take it far enough after the meal that they don't interfere. And sometimes we can find foods that are rich in nutrition for less space in the belly that can settle well with us. So there is advice on this issue. It's definitely known in Parkinson's. And after a person has had Parkinson's for a long period, it can be seen that they suddenly lose weight. Now, if you're losing 30 and 40 pounds, it's very important you see your primary doctor, and we rule out other things that are unwanted health circumstances that can affect weight. But if it happens, it's very common in Parkinson's. Does anyone else want to add anything?
Is this on? It appears to be on. So there's also, we did a study, Robert Eisenberg did a study on weight loss in Parkinson's disease. And so we do have some scientific data. We all have sort of anecdotal understanding of, involuntary weight loss appears to be a bad thing. But Robert looked at all of the weight measurements on a whole bunch of patients who had come through the Fixel Institute over a long period of time and followed their weight and looked at people who had deep brain stimulation surgery before and after and what happened to their weight. And two clear trends came out of that data, which were very interesting. And I think probably not surprising, one of them is not surprising, and that is that people with Parkinson's disease tend to lose weight involuntarily before they die. So it is, like it or not, a bad sign. To Dr. Maladi's point, if you are involuntarily losing significant weight, that's something to tell your doctor. And the other very intriguing finding for me was that Parkinson patients who had experienced progressive involuntary weight loss, who then had deep brain stimulation surgery, gained weight after the surgery. So, we can't say that that's causal, and the two things aren't clearly related. So you can't say that DBS surgery keeps you alive longer, but you might make that assumption based on those two pieces of information that we got from the study. But certainly it was gratifying to see that surgical intervention not only helped people move better, but it actually helped them regain that involuntarily lost weight.
And just to clarify, if you've lost 1 or 2 pounds, don't worry, that doesn't mean you're nearing the end or something. It's just losing a lot of weight has an association that we have to be careful about.
Maybe I'll plug let me just plug we actually brought in a couple of registered dietitians in our group, Matt Beakey and Carly, and they've been a fantastic addition to the Fixel Institute. So we're sensitive to this issue. If you're not getting weighed regularly at our clinic, please let us know. We like to do that because it's important. And if you're having issues with nutrition and weight, we can actually utilize those dietitians, and they have been a fantastic resource.
Okay, Alana has a question.
Okay, so the question I have is,
You have to do the rock star pose. You have to actually do that.
okay, rock star pose. What can care partners do to get more of a voice and more support from the medical community? Well, I would say the very first important thing would be to come to appointments with your partner. I'm assuming that most of you all are doing that already, but if you're not, you should come along. A lot of times people, when they come to see the doctor, they will say, yeah, things are going great. But then you also want to add in the times when maybe things aren't going so great. Oh, but yeah, they've been walking well, but he fell recently, and that's unusual for him. So do that, let them know when there are problems, even though they may seem minimal to you. That gives us a baseline to know when changes are starting to happen, so we can continue from there and address that. So sometimes the person who is there for the appointment may say how they're doing, but you may see something different that your partner is not expressing. So I think it's helpful to give a second opinion on that, another viewpoint, so that the doctor is aware of that to help give support. Sometimes you might want to talk privately with a doctor if it is something that's sensitive, or what am I trying to say here? Something that you don't feel comfortable talking about in front of the person that you're there at the appointment with. So you may want to talk privately with them. You could ask for a few moments alone. You could also message them through my chart. So coming to support groups is a great way to get more support. There are a lot of things that we can learn from each other during the support groups. There's a wealth of knowledge talking with other people who've had similar experiences. And then the last thing I would say is start planning for the future. We know that things are going to change for all of us regardless of what our health condition is. Start asking for help before you need it so you can start planning it. Think proactively about supports that could be helpful to you, or maybe ask what things might I face in the future that I might need to start preparing for now. And that's something that both the medical providers and social work can help with for those situations.
Can I add? I want to share a powerful tool that I tell all of my friends. Before you go to the doctor, for any reason, to any doctor, do your homework. The communication that happens in the doctor's office, we know for a bunch of reasons is imperfect. But one thing that you can do to more effectively say what you need to say is, before you go to the doctor's office, make a half page of bullet points on paper. These are things I want to discuss today, and this is why. Like, this is what matters to me right now. Because the problem is, if you don't do that, you go in and the doctor starts asking questions, and it may go a completely different direction than what you really care about the most. But if you walk in, this is really powerful. When people do this to me, I think, wow, this really helps a lot. They come in and they hand me a piece of paper. Now, don't hand me 5 pieces of paper. That doesn't work at all. If you hand me a piece of paper that is densely typed from top to bottom, that doesn't work at all either, because none of us have the attention span for that, nor the time. And so you have to write your long thing at home and then turn it into 5 bullet points on a half sheet of paper that when you hand it to your doctor says, here are the things that I would like to talk about today. This is what matters to me today. And it's really helpful for us. And you know, the question was, what can you do to get more of a voice? This is a really powerful tool. I recommend, no matter what your doctor's appointment is for, whether it's for Parkinson's or anything, do some homework before you go. Write out a short, you know, it has to be very brief. If you hand them a long thing, then, you know, the doctor's going to roll their eyes and say, look, I don't have time to, you know, read your life story. But if you bring in 5 bullet points on a half sheet of paper, and they're the things you care about, then the communication during that visit's going to go dramatically better, and I think you're much more likely to leave learning something that you were trying to learn.
Yeah, I think it's a different day these days for patients and doctors and the relationships, and I think we are seeing that. So the days of when you go to your doctor and you expect the doctor to tell you everything and tell you what to do kind of have gone the wayside. We really want to be a partner with you, and I think it's your appointment with us. You're what's important to us. So, and we want to listen to you, and it's great when you set the agenda for us. And we don't mind it, actually. So I'll just say that. I'm going to go ahead and answer one of the questions here. I think it's a really apropos question. Someone asked about this new staging system. And I'm excited by the question because I was just in New York City and actually got to see Michael J. Fox and join the Parkinson's Progression Marker Initiative and hear a lot about this new exciting news about a sort of change, kind of a sea change in how we're going to be looking at Parkinson's disease going forward. So the question has to do with this new staging system and sort of this really exciting publication that came out in the Lancet Neurology about sort of a discovery of a biomarkers. So biomarkers are anything you can measure, and in this particular case, it's measurement of a abnormal protein in your spinal fluid, and particularly something called alpha-synuclein. So this is a normal protein that goes rogue in your brain, and is enriched in what we call Lewy bodies. And so Parkinson's disease is actually one of these disorders we call Lewy body disorders. So, and Lewy bodies are things you can't see on a brain scan. It's not something I can just look at a person and say you have Lewy bodies. This is only something we see under the microscope today. But we can measure these things in tissue. And so what's different about this in terms of staging? So, in terms of staging Parkinson's disease, I think many of you asked, am I at the beginning, the sort of the middle, the more severe stage? And there are some research staging that we use so that we're clinical. One example is called the Hone and Yar stage, but it's really a research and something we artificially put on you as a label. So what does it mean to have a new staging system, and how does this protein or a biomarker kind of fit into this? So actually the new staging system involves more than just that. It involves also genetic risk factors as well as clinical factors as well. So it's a little complicated, but I can explain it briefly. But it's what's designed to do actually is to sort of flip things like a coin. Rather than just looking at a patient in our clinic and sort of gauging where are you, we're moving forward as like a sea change to use some of these both genetic and tissue biomarkers and to look at your disease based on the pathology, what's going on in your brain. And why that matters to you all going forward is we're looking at developing new treatments to target that pathology. We want to find ways to stop Parkinson's disease in its track and eventually find a cure. So yay, that's what's been going on. And in order to do that, we need to start looking at you all and the pathology that's going on, and to find ways of putting you all into different trials, okay, that may move the needle forward to finding something that will slow this disease down, stop its track, or cure it. Okay, so that's what's significant about this. So the staging system involves a couple of things. So we want to identify people who don't have disease but who are at risk, and I think Dr. Fair here talked to you about genetics. So there are lots of genes out there that we know, that things that you get. So these are things that either, in some cases, are linked to disease, they cause disease, but in many cases they are just risk factors, okay? And you don't have a choice about your genes, you're born with those, okay? But they do load the gun, okay? So we want to identify folks at that stage, and perhaps we can, in the future, suggest things that you might do. Everyone asks these questions, sort of, what should I do if I got this risk gene? Should I exercise more? Should I eat this? Should I eat that? Should I take this vitamin or that vitamin? What can you do to prevent Parkinson's from happening? We don't have a great answer yet, okay? So we want to look at that. So stage sort of 0 is really risk factor, okay? Sort of stage 1 is if you have an identified risk factor, either genetic or otherwise. Stage 2 is if we can take a risk factor and then add on top of that this new biomarker, okay? So adding this protein biomarker. Now, it's a little overblown so far, but because the way we're testing for this is spinal fluid, and we don't do spinal taps in all of you. No one's really jumping up to do that. So we are looking for other ways to look for this. The holy grail might be a blood test, I think. We're still working on that. So, but we can actually look at these protein biomarkers in spinal fluid, and that's sort of the sea change here. So if we can do a risk factor plus a protein biomarker, that puts you at least in stage 1. Doesn't mean you necessarily have the symptoms yet. So stage 3 is when you start to have symptoms, okay? Symptoms of a dopamine deficit, okay? That means some sign of maybe a subtle tremor or slow movement or shuffling, just some subtle sign. And from there, the staging system basically is more clinical, mild, okay, sort of slight, mild, moderate, and severe. And there are different stages. So I don't want to get into the mud here of all these stages, but I think I want to give you the big overall picture here. is the sea change, in terms of the way we will end up looking at Parkinson's disease as not just clinically, as just coming to our office, but also looking at the brain pathology and what this will do in terms of impacting how we move forward in terms of treatment is being able to design clinical trials better to target you at these different stages. So finding people with the risk factors will be really important, and that's where this gentleman next to me is sitting is really important, those risk factors. But we also need to figure out what to do about those risk factors, okay? And we need design trials for that. And if we can do biomarkers, some way that we can get to the blood test, then that will be the next sort of stage or step to identify. And that may also move the needle forward, because that'll hint at what's going on in your brain, because we know now that this little biomarker is linked to brain pathology, okay? And that's the disease that's happening in your brain. And if we can slow that down and target that, I think that would be great. We want people who have early symptoms, and if we can stop you from, needing a wheelchair in the future, developing dementia in the future, if we can stop his tracks, that would be a huge change. At the moment, I hate to say it, we're all kind of sitting here, all we have is treatments for symptoms. They work really well, but they don't slow the disease down. So that's what's so important about this. So, great question. It's an exciting time, but it's still going to take some time, but I think this is a real interesting change. So.
Why don't we have Dr. Fair go ahead and answer one of yours? We're going to try to, we have a lot of questions, and we're actually towards the end of the allotted time. We'll go a bit over time as long as people want us to. So we'll just try to give as many quick answers as we can.
So just to follow on what Nick was saying, in 1997, the first gene was found, and everyone just thought, it's a one-off. Doesn't really affect people with idiopathic Parkinson's disease. It's just the first gene. In 1998, there was another one. In 2003, another one. 2004, another one. Now we know there's more than 90 regions of the genome that affect Parkinson's disease, and each one of those 90 regions is potentially a target for the development of new drugs and perhaps the development of biomarkers. Now, the biomarker field is going through a similar revolution. 20 years ago, there was no reliable biomarkers for Parkinson's disease at all. Probably, I would even say 5 years ago, there was no reliable biomarkers, perhaps with the exception of brain imaging, directly looking at the brain and looking at fluoridopa turnover. But now, today, there's some really, really exciting news about new biomarkers, and one of them, as Nick was pointing out, was around alpha-synuclein measurements with a spinal tap, but not everybody wants a spinal tap. I had a question which is related. It says, what helps with Parkinson's odor? There's often a musty smell with the person, regardless of the bathing and talcum powder and stuff. And it's an interesting question. There's a lady, a nurse in Scotland, who you may have come across. Her name is Joy Milne, and she's hyperosmic. She has a fantastic sense of smell. Not only does she have a fantastic sense of smell, her mother did and her grandmother did. She was born hyperosmic, and she could tell the difference between somebody who has Parkinson's disease and somebody who doesn't from their sense of from the smell, from their odor. She's working with Manchester University right now. And what they're doing is they've taken sebum, a swab, and it's from this part of the back, and they've subjected that to mass spectrometry, and they've looked at that sebum, and they've identified a whole variety of different types of fatty acids and volatile compounds. And they've put each of those into a little pot, and they've got Joy to come in and say, which one smells like Parkinson's disease to you? And she's identified them. And she can then, with a very high specificity and very high sensitivity, which is absolutely remarkable. You don't need a spinal tap for that, and it's something that I think will become probably one of the most revolutionary tests for Parkinson's disease, because it's also quantifiable. The smell changes over time. Now, most people can't smell it. So whoever submitted this question, you might be hyperosmic. It's not maybe the person you're smelling that's the issue. It's you and your acute sense of smell, which is phenomenal. So maybe it's another Joy Milne, but I think
Let me add to
the
that.
opportunity for biomarkers is huge.
Because I saw the question, that was so perfect, and that was really a fun reminder of that lady. So the question also was, what do I do about that? How do I help that smell? Not everyone has a really detectable smell, but there is an overproduction of sebum. Our sebaceous glands can cause an oily feeling in the scalp, behind the ears, on the bridge of the nose, and behind the neck. And in fact, seborrheic dermatitis is a condition more common in Parkinson's related to this discussion of these overactive sebaceous glands. If you have that dandruffy kind of condition with oily, flaky skin, a dermatologist can give you particular shampoos. There are many over-the-counter that are labeled dandruff shampoo. Some have zinc, some have selenium, pyrimethamine. There's 3 different ingredients. If one doesn't work, try the other. Sometimes they give you a special antifungal kind of shampoo that kills a normal occurring inhabitant on our scalp, and steroids. But in the case of, well, I think my life partner or spouse has a smell that they never used to have, what do we do? Of course, the normal stuff of showering or bathing regularly, if that's an option every day, to help remove the oil. And, deodorant, cologne. But this person specifically wrote, besides that, you could keep baby wipes with you and wipe especially behind the neck, behind the ears. Those would be another practical thing you can try for that problem of removing that oily substance that has a slight odor to it. Would you like to take one, Rachel?
Yep.
I'll take one. We'll kind of go down in a circle.
I'm sorry, I can't hear.
If you want to do one of your questions, please.
So I have some questions about swallow and aspiration risk, one about hydration and other techniques other than using thickened liquids, and then the other one about avoiding aspiration with sucking on candy or drinking. So the main thing we usually recommend is really working together with your speech-language pathologist, particularly getting a swallow study, whether that's a modified barium swallow or another type of imaging, is very important to actually see what the issue is with swallow, to know what the techniques are for helping manage you. We don't automatically, our speech therapists don't automatically recommend thickened liquids. Sometimes there are other techniques like making sure you brush your teeth after every meal and then being able to drink water, or specific techniques that will help for you. So I'm going to recommend seeing a speech-language pathologist to make sure that you have your specific needs met.
That was great. I got a quick one. Is pain relievers such as Aleve dangerous for PD? The first comment is that not all pain relievers are created equal, and it's easy to kind of group them, but Tylenol, Aleve, very different from one another. Aleve, Advil, maybe more similar. Something like Tramadol, entirely different. So my comments will pertain to Aleve particularly. It's a non-steroidal anti-inflammatory drug. No relationship between that and Parkinson's disease, so there's no specific reason that it's dangerous in Parkinson's, with 2 exceptions. One is that you need to talk to whoever sees you as a primary care doctor to make sure there's not other reasons you can't take Aleve. For example, if you have dehydration and you have risk of kidney issue, or if you have stomach issues, sometimes those can be exacerbated by a medication like Aleve. The second is that if you're taking a lot of over-the-counter pain medicine for kind of joint and stiffness pain, you might want to raise that issue when you're being examined for your Parkinson's, only to ensure that it is in fact inflammatory pain. Sometimes it can be really hard to know where those symptoms are coming from, and there are symptoms like stiffness and dystonia that can come with Parkinson's that are unlikely to respond to Aleve, but may respond to changes in the medicine you're taking for your Parkinson's. So it's kind of helpful to keep that in mind, since it might take someone like a neurologist to kind of help disambiguate where exactly which symptom is coming from.
Okay, a few quick ones. Does hyposmia, which means a low sense of smell, being unable to smell things, does that improve with Parkinson's disease treatment? Unfortunately, not really. That doesn't seem to be, the inability to smell does not seem to improve with dopamine medicines. It is an early marker of Parkinson's. Many other things make us lose our sense of smell, like COVID and other viruses or allergies. But the one in Parkinson's usually doesn't improve at this time. Another quick one was, is early onset of depression, anxiety, or delusions considered Parkinson's disease psychosis or Lewy body dementia? I think they mean dementia with Lewy bodies. First of all, anxiety and depression are very commonly early in Parkinson's and not the sign of someone having psychosis, which is where we can have hallucinations or beliefs that aren't in line with reality. Anxiety and depression, super common, can happen very early in Parkinson's. The writer asks about dementia with Lewy bodies, which is sort of a related condition that generally is thought of as distinct from Parkinson's, which is really predominant with dementia, hallucinations, fluctuations where a person may seem fine one minute and confused another, and that's some symptoms of Parkinson's. In dementia with Lewy bodies, within the first 5 years, a person may have dementia and significant cognitive changes and hallucinations, whereas in Parkinson's, we typically see that later in the course if it's going to occur. So just depression and anxiety separate, and having hallucinations usually later. And then I'll do one more quick one and then we'll kind of go back down the line. I think we have a few others. Was night terrors. And my husband is screaming, punching, yelling. What can I do to help with this? And so the interesting thing is that in Parkinson's, this particular sleep disorder called REM behavior disorder, REM stands for rapid eye movement, the deep dreaming sleep. In the normal state of affairs, we're paralyzed when we're dreaming. If I was dreaming, you wouldn't know what I was dreaming about. In this condition, we lose what we call atonia. We lose the loss of tone. Our muscles are not paralyzed, and we kick and we punch, and we usually have vivid, disturbing dreams. Usually they're combative, they're rescuing, they're saving, they're fighting off. And the person will kick, punch, move, roll out of bed, accidentally strike their spouse, and this can disturb the happiness of the bed environment. And also it can disrupt the sleep and cause injury some of the time. So first of all, this is treatable. The most common medicine used is called clonazepam, which can be very effective, usually used at bedtime. It does have risks like cloudy thinking or sleepiness or balance trouble, but it's usually dosed just at bedtime. Sometimes we try melatonin, which is over the counter. And so if it's something that's causing injury or distress in the whole bed health, you should ask about it. Nick, you had a few more?
I'm going to add a couple things. I think this is just related to the same thing. Someone asked about treating psychosis, and I think actually you talked a little bit about it. It's probably worth just stepping back and saying, what is psychosis, that term we use. So psychosis can be a few things. So in Parkinson's disease, people with psychosis, it can be, one manifestation could be hallucinations. That's seeing, hearing, smelling, feeling things that aren't real, okay? So like maybe you may see commercials like seeing that mouse or rat, running across the room when no one else sees that, or having a sense that someone else is in the room. So it can be very simple, but hallucinations don't have to be just visual. They can be tactile or auditory. You may be hearing voices. Most commonly they are visual in Parkinson's disease, but that's one aspect. Another aspect is a term we call delusions. So delusions are fixed false beliefs that may be as simple as like, you think that your spouse is cheating on you, or you believe that someone else is taking things, or that someone is putting poison in your food. It can be fearful, so they can be paranoid. You're worried about something happening bad to you. Or they can be really benign, It could also be kind of not recognizing somebody. You think that your partner is someone else. Okay, that's actually a delusion. You think they're a complete stranger, someone you don't know in your room, and you really believe that. Okay, it's not rational. Okay, so those are examples of psychosis. So what do we do for treating it? So a couple things. First. So there are medications, but I think we should always step back first and think about non-pharmacological approaches, okay? First of all, if they're mild, I think just behavioral things, reassurance, all right? I do tell people with dementia, trying to reason someone who has dementia is not always that fruitful. There are battles you can win and battles that are not worth fighting, okay? So sometimes agreeing, or at least just stepping back and giving them sort of a yes, I understand what you're saying, and just acknowledging it can be a good way to actually dealing with that kind of thing. Okay, so it doesn't always have to be a medication first. okay? The same thing with hallucinations. They can be really benign, mild things, you know. And they don't have to be, you know, obvious things. They can be illusions or misrepresenting. So just those benign things do not automatically need to have a treatment or a medication, okay? So again, there are behavioral or non-pharmacological ways to approach psychosis in an individual, okay? Medications are definitely warranted when they become more disturbing, frequent, if they're, you know, all day long, or if they're actually causing, you know, fear during or issues at night. Sometimes these could be so bad that if they're paranoid delusions, it might actually lead to someone trying to leave the house. I've heard crazy stories, you know, calling the police, the fire department, because they believe that there's somebody outside, or even leaving the house because they feel like the house is not theirs. Okay, they don't recognize it and they're trying to run away. So a lot of situations where, in that case, we do treat. And the main treatments are actually what we call dopamine antagonists. So what does that mean? These are drugs that actually interact with the dopamine receptor, but they block it. So as opposed to levodopa, or the drugs we use to treat Parkinson's disease, that actually enhances dopamine. So if you think about that, they actually kind of counteract each other. So giving somebody a dopamine antagonist does carry a risk of worsening Parkinson's. So there are a lot of ways to approach this. One way might actually be to just reduce medications. So sometimes it's just a balance. Sometimes your medications can be the cause of the psychosis, and just reducing it might be the first step. But sometimes we do have to treat and add some of these medications. There are a lot of we call dopamine antagonists, and some are different than others. And choosing the right one may have less of those anti-Parkinson's effects on you, okay? So it's a complicated question, but basically just bring it up to your physician. We can talk you through it. It is a complicated kind of balance question, and there are lots of approaches to it.
I'll give one a go. I've got a question here about progression and monitoring progression. And it's about, the question says, after an initial DAT scan, for diagnosis of PD, when does the patient get another test to diagnose their progression? I think neurologists would probably answer that better than me in some senses, but every time you go for a visit to see a neurologist, they probably ask you some questions about your well-being, your activities of everyday life. They might ask you to do some motor tests, to do some rapid alternating movements, and they'll stage your level of Parkinsonism in a variety of ways. They might ask you the UPDRS and tick down on some boxes on a score. They might stage you with Hone and Yaw. But for what you can do personally, I'd suggest you go and buy a Fitbit. They're about $40. And seriously, and I think you could get a lot of information about your level of exercise, your quality of sleep, your autonomic function, just from a Fitbit. And I think that's something that I would recommend all patients, actually most people, to have. I think it's very interesting information, and to follow longitudinally over time to see how you're doing. I don't think, I mean, for the most part, patients have one DAT scan, and that might be it. Yeah.
This is our current state, is once you have a diagnosis, we watch what we call clinically, which is how you're doing based on your symptoms. How is that affecting you? Are you having falls? And so we have rating scales we use that rate how is the movement, how is the stiffness, how is the falling, and that's kind of how we follow over time. We've reached the end of our time, and I want to thank the panel, everybody, and all of you, and everybody at home. And if you have a question, either we have it on paper or we don't, that you didn't get answered, please grab us afterwards. Thank you again, Amanda, for organizing everything, and we'd like to thank North Central Baptist Church.